So I'm going to try to keep you awake, even if the topic might seem not really an accurate topic. You know, this is my disclosure. The paper who finally killed the intra-aortic balloon pump is this one, the one from our colleague Holger Thiele, published in 2013, and stipulating that in patients undergoing early revascularization for myocardial infarction complicated with cardiogenic shock, intra-aortic balloon pump did not reduce 12 months all-cause mortality. That's done. We say in French, la messe est dite, ite missa est. So, and when we talk with many cardiologists nowadays, they say we don't use the balloon pump anymore for cardiogenic shock, which is okay with me. If the patients are doing well, maybe better not to put any balloon pump in those patients. Firstly, if we look at the patient in cardiogenic shock, patient with failing heart, there are many questions which are not solved. And I'm not going to give the answer because it's not solved, in fact. One of the questions is there any difference regarding the severity of the shock? You know, maybe balloon pump was not useful for mortality or survival. In the patient in the paper from Holger Thiele, but maybe in patient with more severe shock, balloon pump might help a little bit. I don't know. And the main question is, does the balloon pump help to recover a better left ventricular function? I don't know. There is no answer about that. If you look at literature, it's very seldom, in fact. And another question we could ask is, even if the balloon pump does not make any difference for the 1 year or 30 days outcome regarding mortality of the patient, maybe the balloon pump might help as a temporary support for the patient to wait an ECMO or an impeller or a PHP or whatever. No answer about that. And what about the balloon pump after cardiac surgery? We were discussing just before starting the session with one of my colleagues and saying, in surgery, we still use the balloon pump after revascularizing patient with acute MI emergently. We still put a balloon pump in those patients. I'm not saying it's good or bad. I don't know. We should look at that. So again, this is not because there is one paper saying that the balloon pump is not useful anymore that we should give up on that. And maybe there are many other trials to perform before to really kill the balloon pump. Literature is very seldom, and this is one paper showing that there is and we know that there is a real preload reduction with the balloon pump. Balloon pump does not increase the outflow. We know that. Balloon pump decrease the afterload of the left ventricle, which is good enough. And in this paper, you can see that the balloon pump decrease, maybe not as good as the temporary LVAD system, but balloon pump decrease the afterload of the left ventricle. What is interesting, when there is in this paper, when there is an association with balloon pump and percutaneous LVAD, then there is even a significantly better decrease of the afterload of the left ventricle. And again, we know that balloon pump improves the coronary artery perfusion. So this is something we have to keep in mind if we want not to use the balloon pump anymore. So regarding intra-aortic balloon pump use and peripheral ECMO, of course there are some cons and some pros, as usual. This is life, real life. So the balloon pump might decrease the pump flow during diastole, increase left ventricular afterload during systole, and increase the risk of lower limb ischemia. Even if, when we look at our experience, the rate of lower limb ischemia using the balloon pump nowadays is very, very low, in fact. So I'm not sure this is really an argument. So this is con, but pro regarding using the balloon pump with peripheral ECMO. It adds pulsatility. This is something we have to look at. It improves coronary perfusion. And the balloon pump, as we know, unload the left ventricle and thus might help recovery and prevent pulmonary edema, which is one of the major complications we might face with peripheral ECMO. So one paper, this is not clinical paper, this is in animal paper, looking at peripheral or central ECMO and regarding the effect of controlled pulsation. So they had a left ventricular conductance catheter, arterial pressure sensors, and so on. And they look at the left ventricular afterload This is TTE, tension time index, left ventricular afterload, coronary perfusion, GPTI, and endocardial viability ratio. Only one slide regarding this study. So if we look at TTE, this is one, this is the circle, you can see that using the balloon pump with central cannulation or peripheral ECMO, using the balloon pump might help to decrease the left ventricular afterload. So at least in sheep, it does work. And of course, again, in both type of cannulation, it does improve the coronary perfusion and improve the myocardial viability. So maybe there is something to do using balloon pump associated with peripheral or even intrathoracic ECMO. From the same paper, finally, they concluded that intra-aortic balloon pump retains its unloading and diastolic augmentation characteristic regardless of CLS cannulation intrathoracic or peripheral. So the overall efficacy of the intra-aortic balloon pump is higher when used in centrally cannulated CLS patient. There are not too many clinical papers looking at that. This is one paper published in 2008 looking at a series of 30 patients who had an intra-aortic balloon pump associated with an ECMO. And only in univariate analysis, they show that using balloon pump associated with a peripheral ECMO might help the survival of the patient. So this is what we try to avoid when we have a patient who is on peripheral ECMO. And we know that when we have this increase in left ventricular afterload, this can lead to blood stagnation into the left ventricle and even clot formation. And if you have a patient who experience an acute MI, we know that the inner surface of the left ventricle is very thrombogenic, and then there is a high risk of clots. And if you have this stagnation into the left ventricle and even the aorta, of course, we know that this can lead to pretty bad pulmonary edema. And this is what we want to avoid, because we know when this happens, then it is very, very difficult to get rid from this edema, even then if you unload very well the left ventricle. So we started to study that a few years ago, and this is a paper we did publish in 2014. And at that time, we looked only at 14 patients. This is a small series of patients who were on peripheral ECMO, supported with peripheral ECMO. They had laminar flow, so no pulsatility at all. And they had an intra-aortic balloon pump associated, and they had a Swan-Ganz catheter. And every single patient was its own witness. So we look at the hemodynamic data when the balloon pump was on, and then we stopped the balloon pump for 30 minutes, and we recorded the data again from the Swan-Ganz catheter, and then we switched the balloon to on, and again, after 30 minutes, we recorded the hemodynamic data. So this is the result we had. Maybe we just can look at the wedge pressure. Everything is altogether is very consistent, but just look at the wedge pressure. So when the balloon pump is on, the wedge pressure as a mean is 15. After 30 minutes, the balloon pump was off. The wedge pressure went up significantly to 19. And again, we switched the balloon pump to on, and 30 minutes later, it was back to 15. So just looking at that, that means there is a real significant role of the balloon pump in patients who are on peripheral ECMO to decrease the afterload of the left ventricle, so trying to get some benefits to avoid the pulmonary edema. Another way to look at that, this is all the patients included in this trial, and you can see that higher is, in most of the patients, higher is the wedge pressure when the balloon pump is off, better finally is the effect of the balloon pump either before or after when the balloon pump is on. So again, this is why in our institution nowadays, particularly for patients who have acute MI-related cardiogenic shock, or patients who have chronic heart failure, who experience on the top of that acute decompensation, in those patients, it is mandatory to implant a balloon pump associated to the peripheral ECMO. So this is a more recent trial we did, looking at some of the patients we implanted between 2007 and 2012. So we selected about 600 patients who had peripheral VA ECMO. We excluded some of the patients. You can look at them here. And finally, we came up with a nice population of 278 patients who had peripheral ECMO, and 177 had no associated intra-aortic balloon pump. This was mainly the first era of the study. And then 101 of the patients had received an intra-aortic balloon pump associated to peripheral ECMO. And we just asked the radiologist to blindly review the X-ray of the patient. So we had a mask so that the radiologist was blinded regarding the fact the patient had or no balloon pump, and the radiologist looked a Weinberg radiological score to score the pulmonary edema of the patient. And then the biostatistician did a matching score to match the population, because again there was a bias, because the population without the balloon pump was an early population, and the population with the balloon pump was a late population. But anyway, they did a matching between the two populations. So this is what we came with. So this is unmatched patient. This is the patient after we did match. Maybe we can just look at this table, forget the other one. So this is the mean age of the patient was 50, similar in both groups. It was 72 to 74% of males. Year of inclusion was quite similar after matching, makes sense. If you look at inotrope and so on, because of the matching, it was the two populations were comparable. And we came with this result. This is before matching, and this is after matching. So, of course, before matching, we had a huge difference regarding the survival free from pulmonary edema after a few days. This is only after 10 days. But even after matching the two populations, we still had a significant better survival free from pulmonary edema in the group who did receive a balloon pump in comparison to the patient who had only peripheral ECMO without the balloon pump. And, you know, this is statistic and so on. But then when we look at the patient we do have, I can tell that because we have a lot of patients on ECMO, close to 300 to 400 a year. So when we look at the patient, before we use the balloon pump associated to the ECMO, we had a lot of patients who did experience pulmonary edema. And then those patients, many of them did die because of that. Nowadays, pulmonary edema, I would say, occur in 10 to 15% of the patients. So in those patients, we still have to be more aggressive, but this is only 10 to 15%. In the old time, it was mainly 65 to 70%. So again, looking at the outcome of the patient, there was a difference in survival, but only in the unmatched series. Then when we look at the matched patient, if you look at the survival, it was not significantly different, even if there was a trend for better survival in the patient who get an intra-aortic balloon pump. But again, it was not significant, maybe because the power of the study was not designed for that. Just to end this presentation, a recent experience we did have, because some of the patients who have to face, particularly after cardiac surgery, you know, we have some patients who had a Benthal procedure plus a cross, an aortic arch surgery and so on. Some of the patients experience pretty bad heart failure after this surgery, particularly if they have a bad left ventricle before. So in some of the patients, we do implant an ECMO in those patients, and the risk, if we do use a mechanical valve, the risk, of course, as you know, is to get a clotting, a thrombosis of the mechanical valve. So we have this is only a small experience. It's only 5 patients who have a mechanical aortic valve prosthesis, and who were supported with a peripheral ECMO. And just we did try to support them with peripheral ECMO and balloon pump to try to get a better washing of the aortic root. And in those patients, interestingly, so there was 4 patients who had only a mechanical valve in aortic position, 1 patient had a mechanical valve in aortic and mitral position. So we had 1 death, 2 recovery, and 2 finally did not recover and were bridged to transplantation. But there was no clotting of the aortic mechanical valve in the series. So this is something I'll give to you. I don't know what to do with that, but except that nowadays we are more confident if we have a patient who requires a peripheral ECMO and who has a mechanical aortic prosthesis, we are more confident to assist them using an ECMO plus a balloon pump. So as a conclusion, I would say we have some convincing experimental as well as clinical data suggesting that intra-aortic balloon pump might improve hemodynamic of patients on VA ECMO by decompressing the left ventricle and by maybe improving coronary artery circulation. This improvement is retained regardless cannulation sites regarding literature. So impact of intra-aortic balloon pump, we try to look at that. We didn't see any significant improvement in microcirculation due to pulsatility of the balloon pump, but I think this is something which has to be still addressed. Thank you very much for your attention.